All right, welcome everyone. We're going to get started. Thank you guys for all coming to the Psychosocial Research Showcase. Test, test. That sounds better. Thank you. All right, everyone, we're going to get started. Welcome to the Psychosocial Research Showcase. My name is Jennifer Butcher. I'm a pediatric psychologist from the University of Michigan, and I'm joined in moderating with Maura Harrison, who is a clinical social worker at Boston Children's Hospital. So for this session, it's an abstract-driven session, so we reviewed psychosocial abstracts and just tried to make a session that covered a breadth of different topics in psychosocial research, different methods of research, and different population ages. So we hope that you enjoy. Our goals are to explore the variety of methods, a range of populations, and to help the psychosocial support needs across different areas of risk. So I'm going to introduce our first speaker as I bring up her slides. So I'd like to welcome Caitlin Heinbrook. She is a third-year pediatric resident at Cincinnati Children's Hospital, and she's presenting on navigating school with CF.
All righty. Hi, everyone. Like she said, my name is Caitlin. Today, I will be sharing our work that looks at navigating school while living with cystic fibrosis. The typical two first slides, I have nothing to disclose relevant to this talk today. So starting from the beginning, as I'm sure all of us are aware of, despite the many treatment advances that have happened, managing cystic fibrosis during the school-age years continues to require a daily schedule where patients have to focus on balancing the responsibilities of medical treatments, academic tasks, and other wellness activities. Our work here really started with the study that we published last year that found that 62 to 82% of children with CF, depending on who you're asking, are at elevated school risk. Now, what does that really mean? Elevated school risk means that these children have higher need for school accommodations. They have more concerns with school performance, and they also have more attendance issues in the general population. And all of this is really important to think about because, as I'm sure all of us can understand, educational success and attainment are really strong predictors of future health and functional outcomes later in life. So the goal of really focus of our study was that in order to optimize educational functioning and provide proper support, it really is essential to understand the unique needs and perspectives of people with CF and their caregivers. So our group decided to perform a study to assess needs. We did a cross-sectional study that was conducted in August of 2024. This was an electronic survey distributed in a couple different ways, so via the CFF Community Voice platform, as well as by care teams directly to their families. Respondents were kind of chosen whichever category they fit into. So caregivers who were completing the surveys alone, caregivers who were completing the surveys with the input of their child with CF, or individual completion, which really is represented by people with CF who are 18 or older. Our team then looked at all of these responses, de-identified them, and then during our analysis, we did exclude surveys that were incomplete and surveys that were accidentally submitted by members of the care team instead of the categories above. So what did our demographics look like? For the rest of the talk, we will kind of divide those three groups I talked to into two separate groups. So we have a person with CF group, which is composed of the people with CF who completed the response individually, as well as the caregivers who completed with input from their child with CF, versus caregivers who completed the survey alone. In total, we had almost 150 responses, and you can see the demographics between the two groups are overall fairly similar. The biggest difference highlighted here is that the person with CF group has a slightly higher age compared to the caregiver group. But all of the other demographics look fairly similar. We had a pretty good representation of different states across the US. Both groups had a relatively even split of male-identifying and female-identifying respondents. The majority of respondents identified as white, and then we had a variety of different types of schools represented in the survey, which was really interesting. So the majority representing traditional schools, but private schools, online schools, and homeschools all included in this survey. So the first question that we asked was really to kind of just get a general basis of what our CF centers already asking patients and their families about. We see that the majority of respondents indicate that they're being asked kind of the basic simple things. What grade level are they in? What kind of school do they go to? Do they already have a health plan, like a 504 or an IEP? As well as kind of trying to assess how CF symptoms are impacting their school. Interestingly, we have a much lower population of people who are responding that they're getting asked about things like speech language services. Are they in them? Are they worried about them? Not many people getting asked about difficulty getting to school. Some people getting asked about absences and whether there are truancy-related concerns. And then interestingly, about 20% of our respondents indicate that they have actually worked on getting that release of info for CF care provider team members to actually talk with schools themselves. The next and probably one of the biggest questions that we asked is, what is the biggest challenge that you face as a person with CF at school? So kind of varying responses. I have a lot of data and we had a lot of different selection topics, so I apologize. These slides are kind of busy, but we'll walk through them. So hopefully you'll be able to grasp everything that I'm trying to share. The biggest response from both groups by far was the impact of illness of CF on school. That was followed closely by balancing school health. Some of the other common topics that we'll see multiple times represented in our data is that their biggest challenge was understanding of school teachers and school administration of CF illness. Next, we move on to kind of a group that I think the people with CF are acknowledging as a bigger challenge a little more than the caregivers themselves. So we have school plans, so those 504 IEP programs, bathroom access, support systems that people with CF have, as well as cognitive or developmental challenges. And then we see a couple of topics that seem to be more of a bigger concern for the caregiver group, including nutrition and energy needs and absences. Our next set of questions started to kind of investigate how these conversations are happening outside of the clinic environment, as I'm sure all of us know that there are lots of different ways that that can happen. So again, with our two different groups, our people with CF group and our caregiver group, this question is asking how that communication currently happens. So probably not super surprising, we see that patient portals, so things like MyChart, emails, and phone conversations are the top 3 categories for both of the different groups. A small minority of respondents endorse using text messaging and video-based communication in both groups. And then a very few people don't communicate outside of clinic. And then we also asked what people would prefer to actually have these communications. So I have the smaller pie charts here from the previous slide just for comparison. And we can see overall that they're relatively similar. People with CF would probably maybe prefer slightly more email communications, but similar patient portal and phone communications, as well as we see that kind of same trend in the caregiver population. Interestingly, the biggest difference between these two is that we see that many more people would actually prefer to communicate with text messaging. That would bring up kind of a whole other issue of patient privacy. How do we navigate around HIPAA, FERPA type things? But interesting to think about, as well as video-based communications continuing to be kind of a lower percentage of preference. Our next group of questions then continues to focus on more specific details that people are deciding to talk about with their care team. So what referrals have been discussed with their CF care teams? Just want to point out that any of these referrals only maybe reached about 1/3 of these respondents endorsing that they were discussed about. The most common referral was about ADHD, followed kind of closely by learning and achievement. The next common groups of referrals include kind of all of the therapies, so physical therapy, speech and language therapy, occupational therapy, and kind of general development. And then a minority of referrals discussed include things like worrying about cognition and memory, as well as being referred for specific intelligence testing. Next, we asked, what kind of specific accommodations have you discussed with your CF care team? Again, busy slide, we'll go through it slowly, and we can see a couple of themes kind of coming out in this. The first couple most popular answers were working on getting access to enzymes and other medications, bathroom access, bathroom passes, allowing to be able to use the bathroom when they need, as well as carrying a water bottle. The next kind of big group of things I think fit into kind of the circumnavigating illness in the school and the worries that that comes with. So we see a lot of people endorsing that they've discussed allowing the student to sit further away from others in the class who have an illness, having access to hand sanitizers, being made aware of general illness in the school. And then I'll come back to this one in a second, but also being made aware of if there's another kid with CF in the school, as well as kind of having personal supplies, access to private water bottles and things like that. And then this one that I did skip over, just kind of interesting, extended time to make up work after an absence. About half of people seem to have discussed that with their care team. And then lastly, probably what I think is the biggest, most important question that we asked is, what do our patients and their families actually want us as the CF care team to help out with? Interestingly, the biggest was actually completing school forms. That's followed closely by providing education about CF to the school. Then by developing school plans, so working on those 504 IEP plans with the school. And then these next two, I think, kind of just highlight the importance of these prior two is really the communication, that we can kind of intervene and help the family communicate with schools in regards to whatever concern we're having, whether it's from access to things versus the accommodations that they're needing. And then lastly, we see that actually a decent proportion of people would actually like people of their CF care team to actually attend a school meeting to probably help accomplish all of these other things that they have asked about. So a couple of big things that we are deciding to take out as our conclusions from the study. Importantly, this is the first examination of school-related issues from the perspective of a person with CF and the caregivers of people with CF. We've identified that there are a couple of major challenges. Number one being the impact of CF illness on school functioning in the numerous many ways that we've kind of talked about it coming up. Next is balancing school performance and health, which is an important thing that we can help our families focus on as well. And then unfortunately, it seems that a poor understanding of CF by teachers and school staff is kind of making some of these tasks and accommodations a little more challenging for our families to get. The next thing that we think is important to take from this study is that people with CF and caregivers overall seem to report fairly similar challenges that they see between school and navigating it with CF. But we see a slight difference in some of the specific accommodations and the bigger worries that people with CF have in comparison to their caregivers alone. So I think really the biggest takeaway point from our work that I want to share with you is that I think discussion of school concerns should really be a vital part of routine CF care, even with, and I think especially with, the improving clinical health that we're having for our people with CF. We, as part of the care team, have a unique opportunity to address these challenges, help out with the need for accommodations, and advocate for our patients to really help promote their well-being overall. I think it's important that we also remember that we should continue asking students and their caregivers what kind of needs and what kind of help they would appreciate in order to provide a comprehensive understanding. And then lastly, it's really important, I think, that patients and families are comfortable addressing these concerns with their CF care team and do have some slight preferences on how that communication happens. So moving forward, our team kind of foresees these supports being really easily incorporated into kind of pre-existing CF transition programming that focuses on education and life skills that are important for the school setting. So to that end, our team has actually been working with the Cystic Fibrosis Foundation to develop a resource toolkit that can help providers and families navigate school better while living with CF. If you want to scan this QR code, it'll ask you just for your information, and then it has actually a very wide number of things you can check about information you would like, but the CF Foundation will send out the materials that we've created after the conference. So with that, I'd like to say thank you for the team who have worked on this study with me, helped doing the analysis, coming up with the talk, everything. Cincinnati Children's, who supporting me to come here, from the residency program, the Department of Palm, and then Marissa, our CFF contact. So with that, I'll take any questions, and if anyone else wants to talk more in depth about this, we do have a poster tomorrow, number 523.
Can anyone hear?
No.
All right, everyone. Sorry about the sound quality.
Very echoey.
I'm not sure if should we turn it back down, maybe? Okay, we'll keep working on that. So if anyone has questions for Dr. Heinbrook, thank you very much. That was a wonderful talk. Please come up to the microphones or submit them in the app too, so you go to our session. Are you waiting to do a question? Come. No? No? Anything at all? No? Okay. Okay, I'll start. So it was really interesting that it seemed like parents really and the children really wanted support more around the learning aspects. But a lot of the school interventions that we're doing are more related to the medical aspects of things. What would you suggest for care teams they could do more to support, like when kids come back from absences, or more of the kind of the learning needs of the kids in addition to the medical needs?
I think that's an interesting question, because I think that brings up one of the things that I think is important between the two differences, or between the two groups, and how the caregiver group did represent slightly younger children. I think we've actually learned a lot from this already, and are starting to incorporate, getting kids into all of the different therapies that they would need earlier on as part of our CF care team. But I think this has also shown us that we should, I think that piece of educating the school is really important, to share why children are going to be absent for more frequently, and why we need to worry about illnesses in the school, because something that, sets another kid out for a day or two might not have the same effect. So if we kind of at the beginning, when we're working on that 504 plan or IEP plan, in the beginning of the year, we can kind of set those expectations that if they're out, they might be out for longer than you more expect, and what kinds of things can we do from getting online access to materials, or things that they can do from a home/school perspective.
Thank you. Please go ahead.
Hi there. Thank you for your information. I had some questions. Have you provided this survey in Spanish, or was it only in English?
It was only in English.
Yeah, I was just thinking, I feel like a lot of our Spanish-speaking families have a hard time navigating the school system in general. So I think that would be a really big opportunity to further get some research on what they struggle with the school system in general, accommodations, like that's a whole new thing.
And with communicating everything to the family too, I agree.
Yeah, so I think that'd be exciting to see if we could get some more voices of our Spanish-speaking families.
Yeah, I love that idea.
Yeah, cool.
Hi. I'm a little too short for this microphone, but I wanted to add, my name is Marissa Taylor. It's been great to work with the Cincinnati team on this project. The QR code that Caitlin shared to access the toolkit does have some materials linked in it that are in Spanish. So I know the research didn't focus on the Spanish population, but there are some school materials that can support you and your Spanish-speaking community in that toolkit. That it's linked into the my.cf resource library. Thanks, Caitlin.
All right, thank you, Dr. Heinbrook.
All right, next up, I'd like to introduce Dr. Manuela Sinistera, who will be presenting on caregiver perspectives on illness burden and social support needs in the context of CF management, a mixed method study.
Thank you. Let me just get my timer set up. Okay, yeah, I'm really excited to be here today. I'll be talking about some of the findings from my dissertation study. I have no conflicts to disclose. Sound okay? Okay. We all know that CF management is complex, it's time intensive, it's multi-step, and CF management in infancy and early childhood is pretty unique in that treatment expectations fall primarily, if not completely, on caregivers. And that leaves caregivers at risk for increased illness burden experiences. And what I'll be talking about when I refer to caregiver illness burden, it's this stress and these additional challenges on someone's emotional, physical, social, and financial well-being that can result from caring for someone with an illness or a disability. So what does that look like in CF specifically? There was a systematic review that was done in 2020 that looked at CF burden across caregivers of adult and pediatric patients with CF. And this graphic over here on the right shows us that in general, caregivers of pediatric patients with CF are experiencing above mild to moderate illness burden according to the Zarit Burden Interview, which is a measure of illness burden that was adapted from for measurement of caregiver illness burden in neurodegenerative populations. We also know that caregivers of youth with CF experience elevated stress, depression, and anxiety. And there have been some qualitative studies that have looked into some of the contributors of burden and stress within CF specifically, and that includes caregivers reporting increased feelings of isolation, guilt, powerlessness or loss of control in the face of CF, and adjustment to overall CF demands. Caregivers have also shared that there's sort of this concrete or more sort of tangible burden associated with needing to seek out resources or financial supports to navigate CF. Okay, so we know that caregivers are experiencing extra challenges. This is an additional stress above and beyond general parenting responsibilities. What do we do about it? So one of the sort of areas that's been discussed in other pediatric illness populations as a potential avenue for supporting caregivers is leveraging social support across different sources and in different contexts. We know that the availability of support is linked to positive psychosocial functioning and well-being among caregivers, and then improved supports for youth and youth treatment adherence and long-term illness outcomes. So that makes sense, right? Caregivers are feeling better supported, they're better able to support their children, and then that can trickle down into treatment adherence. And that brings us to the current study, where we first wanted to quantitatively establish a relationship between social support and illness burden, and then take a deeper dive using qualitative methods. We wanted to determine what are the contexts that caregivers are reporting sort of exacerbate or alleviate illness burden, and how does that change over time? And then we wanted to understand how social support can sort of help or hinder these burden experiences. And then finally, because we had this overarching goal of sort of taking a deeper dive into how we can better support caregivers, we wanted to also collect caregiver perspectives directly on some factors to consider when developing any sort of future support program. Okay, so we recruited 56 caregivers of youth ages 0 to 12 across 4 CF centers on the eastern US. Caregivers were mainly mothers. They identified as white. Let's see if I can use my mouse. Yeah. About half were married, and it was a pretty highly educated sample. Almost everyone had at least a high school degree. I will draw your attention to the caregiver illness burden measure. We use the same measure as the one that I showed earlier in the systematic review, the Zaret burden interview. And in this sample, our mean was about a 28, which falls in that mild to moderate cutoff, pretty similar to what the existing literature is showing as far as what caregivers report is their burden experience in CF. Okay, going back to our first aim, we wanted to first establish that quantitative relationship. Is there something going on between illness burden and social support? And the answer is yes. There was a significant negative relationship between the two constructs. So higher perceived social support was related to lower overall illness burden in this sample. So that sort of confirms our hypothesis there, but it doesn't really tell us much in addition to that, and that's where the qualitative piece came in. We really wanted to understand, how does this play out day to day for caregivers? The first piece of our qualitative interviews, which were sort of mapped onto those constructs that we were assessing quantitatively, we interviewed 20 caregivers from the larger sample. The first piece was to understand what disease-related experiences contribute to illness burden. One of the first themes that came out was this idea of uncertainty at diagnosis contributing to emotional burden that caregivers were experiencing. And that could have been not being familiar with CF prior to receiving the diagnosis. That also looked like having uncertainty about their child's prognosis shortly after birth, having to receive medical intervention due to CF complications early on. Like this caregiver who shared, I'll admit, I was a wreck. I had a textbook perfect pregnancy. I didn't have high blood pressure. I didn't have morning sickness but a few times. And to deliver 2 babies, and one of them is having to be flown to the hospital, it was devastating to me at the time. Caregivers also shared about this idea of adjustment or negotiating a new normal following diagnosis. And there were sort of two sides to this coin. Some caregivers shared that they sort of made CF fit really easily. That adjustment period and that coping period felt pretty smooth, like this caregiver here. And then others sort of described a little bit more challenging, more bumps in the road, not as much of a linear adjustment, and that sort of seemed to contribute to increased illness burden. Caregivers also shared about this idea of coping with long-term health concerns. Similar to that theme above, there was two sides of the coin. Some caregivers coped really well and sort of felt like managing things one day at a time was really protective against illness burden. And then some caregivers shared that this sort of anticipation of future challenges really contributed to that emotional burden that they were carrying day to day. This caregiver here shared, the only negative I would say that comes with CF, aside from going through the emotional roller coaster of knowing she has it, to knowing she's perfect today, but tomorrow medicine may not work the way it is. One day she may need a lung transplant. This caregiver went on to share that sort of anticipating those future complications made it really hard to sit with sort of finding positive news or seeing their child doing well in the present moment. There were also some themes that came through around CF symptoms and daily treatments. And I think this anecdotally, as clinicians, we can probably make sense of, right? So for caregivers who felt like they had a lot on their plate, like this caregiver who was describing CF as a full-time job, felt that increased illness burden across the board in terms of a sort of emotional burden and tangible, like day-to-day tasks, feeling like they were more time-consuming and more challenging to complete. And the reverse was true as well. For some caregivers, their child really was not exhibiting as many symptoms, and that felt like it was lightening some of the burden load. Caregivers also shared about CF exacerbations and hospitalizations and the way that experience might contribute to illness burden. The first caregiver here shared exacerbations are pretty stressful when he's getting up and we're doing 3, 4, 5 treatments, especially in nighttime. My child can't sleep well. My wife isn't sleeping well. There's a lot on everybody. And then we have the vice versa true as well. For some caregivers, being able to make a comparison that like when we're out of this exacerbation and where we're having less frequent hospitalizations, I notice it feels a lot less stressful. So since she started the modulator, that's the year that something clicked. We haven't been in the hospital all the time, every single month. It's a lot less stressful. Of course, caregivers also highlighted socioecological factors that were outside of CF and may have contributed to CF or sort of had like a trickle-down effect, but weren't necessarily disease-related, that definitely contributed to illness burden experiences. I mapped it here onto the socioecological model. Caregivers described challenges like their child having comorbid diagnoses that impacted CF management, so things like ADHD, autism, having their own mental health concerns, depression, anxiety. Also, other caregiving responsibilities. Some caregivers had multiple kids in the home with CF or other health needs and sort of were finding themselves juggling multiple caregiving responsibilities that were pretty specialized. And then we get into sort of like these structural influences of burden, right? So navigating the healthcare system, insurance-related barriers, employment benefits, having to take off time from work for hospitalizations, healthcare policy, all of those things came into the picture as well. Okay, for our second aim, we also wanted to understand what the sources of support were that caregivers were using that sort of helped or hindered burden, and sort of how those things look different depending on the stressors that were coming to light for caregivers. First, I'll share the sources of support that were primarily identified by caregivers, and that was partners or co-caregivers, extended family and friends, healthcare providers, school staff, and social media, usually CF-specific social media. And I will say this group sort of, it looked different caregiver to caregiver, and looked different over time. So some caregivers shared about ways in which extended family and friends were really present right at diagnosis and then sort of faded back a little bit, and how that sort of like shifted caregivers, like where they wanted to search for different support systems. Same thing with healthcare providers, that shifted. There were a handful of caregivers in our sample that, sorry, I'm just noticing an echo. There were a handful of caregivers who shared sort of transitions between medical institutions or transitions in healthcare team members, how that sort of shifted relationships and how they noticed support change depending on how those like structural changes were happening. And then caregivers also shared about how they sort of sought different kinds of support from different sources. So caregivers were more likely to turn to partners or family and friends for that sort of emotional, affectionate support, and then more likely to go to healthcare providers for informational support. One of the perspectives that I found really interesting was this idea of there being sort of limitations to the kinds of, or maybe the degree of support that people in their support network could provide because they didn't have these unique experiences with directly caring for a child with CF. So this quote here, I think, summarizes that well. I have a close friend I will occasionally vent to. It's hard at the same time, too, because they can only really understand so much. There's so many aspects when it comes to a child with CF. And I think that dovetails really nicely with our final component of the project, where we really wanted to understand caregivers' preferences for any future support program. So we're recognizing that this is an issue, and if we want to do something about it, what is important for us to keep in mind that would be most helpful for you all? And one of the things that most caregivers shared about was this idea of having opportunities to connect with other CF families. One caregiver shared, I know every CF journey looks different because of different variants. Children react different ways, but it's helpful with somebody that has a similar overall experience. The other very valuable insights that caregivers shared about were sort of more related to logistics or sort of like a structure of what a support program could look like that would most easily fit into their typical routines or already busy lives. And the first was the idea of having flexible participation opportunities, so things like having virtual participation opportunities for folks who might need to travel very far, or might have trouble fitting different programs or different meetups within their schedule. And then this idea of individually tailoring supports. And there's sort of a couple of different examples that came out. The first was the quote that's listed here. It would be hard to connect with other parents that are having success in managing their child's CF with modulators. This was a family that was not eligible for modulators, and so sort of was bringing to light this idea of being thoughtful, like if we are going to connect with other families, I want to connect with a family who can understand my experience, and I'll feel like we'll be able to build a relationship in that way versus feeling like our experiences are so different and then I'm feeling sort of like negative emotions around my child's journey because we're not using modulators and the other family is having success with it. And then there's also this piece of sort of being able to individually tailor supports across a timeline depending on what caregivers may need. Some caregivers said, it would have been really nice to have extra supports right at diagnosis. Others said, nope, that's too overwhelming. I wouldn't have wanted sort of like an influx of support from the clinical team. And so being able to sort of like meet caregivers where they're at, depending on their support, on their challenges across the illness trajectory seems really important, and caregivers are highlighting that. Okay, to wrap us up. Caregivers of children with CF experience mild to moderate illness burden, and that seems to align with the existing literature. Caregivers also shared about the way in which disease-related and socio-ecological contexts influence burden. And then from a quantitative and qualitative perspective, there seems to be a relationship between this availability of supports and caregivers experiencing alleviated burden. Participants are pretty interested in future support programs. They highlighted this idea of connecting with other CF families to increase support. So sort of being able to get that social support that seems to be buffering for illness burden, but directly from others who understand what they're experiencing. We want programs to be flexible, individually tailored, and easily integrated into their existing routines as well. Just want to acknowledge the funding sources for this project. Very special thank you to the co-investigators, study staff, families who enrolled in the study. And I'll pause there because I know I'm a little bit over time. Questions?
Thank you so much, Dr. Sinistera. At this point, anyone who has a question, we encourage you to step up to the microphone or use the Q&A feature on the app.
Great dissertation. Definitely something you can be proud of. Did just wonder a little bit, like, your findings seem to implicate that, yes, social support might buffer against, disease burden, but I wonder if it might also go the other way. Like that could be a bit of a bidirectional relationship where as your disease burden goes up.
Sorry, I don't want to cut you off. I'm just having a hard time hearing. I think the mic is a little bit muffled.
The mic's a little muffled?
Yes, sorry.
Is that any better?
Yes, I think
okay,
so.
Cool.
Yeah.
I was just wondering if you thought that relationship might be bidirectional, whereas your disease burden increases, your social support might actually decrease, just because you're not going to be able to engage as much socially if more of your time is spent on care.
Sorry.
He's asking if it's bidirectional, so if your disease burden increases, your social support decreases. So did you find?
Oh yeah, that's yes, very interesting. I think there were a couple of examples where, for example, that experience that I shared earlier of sometimes caregivers said like diagnosis was quite overwhelming, and that sort of meant like I don't want additional support. It sort of would feel like too much of an influx. And so that does make me wonder about this bidirectional relationship is sort of what I think we would need to understand a little bit more about, like what are coping tools or what are coping approaches that caregivers typically use with that really high influx of illness burden. Is it, I think it would look quite different if caregivers are reporting, when illness burden increases, my tendency is to seek out supports, and then versus sort of my tendency is actually to retreat, do some like individual problem solving, then I think we might see like heightened illness burden, decreased social support if we're sort of like retreating and doing some problem solving on our own. Thanks for the question. Sorry about the sound. Oh, yeah.
I'm wondering, so, I'm thinking how, not everyone has the same degree of natural support through family and friends. And did you see a specific discretion between the amount of disease burden that was alleviated depending on where the source of social support was coming from?
Yeah, that's a really, really great question. I think it is sort of falling into this idea of next steps, and we want to take a deeper dive into, first of all, not only being able to look at these relationships longitudinally, so like how does illness burden change over time, and what are caregivers reporting as their sort of like primary sources of support at different time points, and I think that could help sort of give us a little bit of information about that. Also, I think it varied so much caregiver to caregiver in terms of like who their primary supports were and their support needs. So for some caregivers, navigating diagnosis felt like they really wanted to jump in and work with the medical team and collect as much informational support as possible. And for others, really leaning on sort of family and friends. And so it was less so about like what the illness burden challenge was and the source of support. It was more so like what are the individual support needs and how do we sort of like approach coping in a way that's support based. If that makes sense. Thank you.
Thank you so much.
Okay. Our next speaker is Dr. Gabriella Oates. Dr. Oates is a social epidemiologist and associate professor at the University of Alabama at Birmingham Medical School in the Division of Pulmonary Allergy and Critical Care Medicine. Dr. Oates will be presenting on a smoking cessation intervention program.
Thank you, Jennifer. I have a question to the sound desk. Is there anything I can do to help with the echo, the way I stand or direct the microphone? It's very hard to hear. Okay. Is that good? Okay, nothing to disclose in relation to this presentation. Apologize for the sound and the mix of echo and East European accent, not a winning combo, but I'll try my best. I'll focus on findings from our clinical effort against smoke exposure in CF, or CF clinical trial. Specifically related to hair nicotine levels in children with cystic fibrosis. In this presentation, when I talk about tobacco smoke exposure, I'll refer both to secondhand exposure, which is inhaling the smoke from a burning tobacco product or the smoke exhaled from a tobacco user, but also I'm including third-hand smoke exposure, which is coming into contact with smoke residue left on objects, clothes, hair, skin, by a tobacco user and ingested or inhaled by the child. We know that the prevalence of both types of smoke exposure in the CF community is substantial. Based on self-report from caregivers, it's about 1/3 of children. This proportion is much higher in families with lower socioeconomic status as measured by income or education. It's also significantly higher outside of the United States. Based on objective measures of exposure, such as hair nicotine, we know that almost 2/3 of children are exposed because of those biomarkers. So why this is important is because this exposure is directly related to CF child health. Importantly, it reduces the functional expression of the CFTR gene, increases airway inflammation, and reduces the efficacy of CFTR modulator drugs. We have a number of studies that show that even the minimal amounts of exposure make the drugs not work as well as intended. So this is, it has a very high clinical importance. Very briefly about CCF, because we have presented on it before. It was a multi-component intervention tailored specifically to parents, grandparents, and other family care providers of children with CF. It was delivered by a trained tobacco treatment specialist who was integrated in the multidisciplinary CF care team. Trial participants were smoking caregivers of pediatric patients with cystic fibrosis, and we allowed for the participation of multiple smokers per family, including extended families. So briefly, our study design was a randomized, open-label controlled study with 2-to-1 parallel assignment, meaning 2 times more participants in the intervention arm. So the intervention arm received CF-specific education about smoke exposure, but also received intake assessment about their readiness to quit, their needs and barriers to quitting, motivational interviewing, as well as the tobacco treatment intervention over the course of 6 months. That includes nicotine replacement therapy, or NRT, behavioral counseling, and other support. The control group only received the tobacco smoking cessation education part. And in both groups, we collected baseline and 6-month smoking history, nicotine dependence, perceived stress data, as well as the child hair samples that we'll focus on today. So what was the education component that was common both to the intervention and the control group? Here you will see an example of a poster. All of the materials, video, brochures, posters in clinic, they included very detailed information about the sources of smoke exposure and the harms of smoke exposure specific to the health of the child with CF. On the video, we also had a testimonial by a CF parent who was former smoker and their now teenage child with CF. We also included steps for quitting on our printed materials and made this as specific to cystic fibrosis as possible. The tobacco treatment specialist was the person who delivered the education to both groups, so there was no difference in delivery. They were integrated into the CF care team in a very, very intentional way. There was protocols developed for referring and scheduling and documentation of their services. They were part of the weekly pre-visit meetings of the CF care teams. They had templates about the intake assessments and the follow-up counseling. And we had an entire intervention manual that included needs assessment scripts and other information so that the trial is uniformly delivered. I would like to draw your attention here to the template letters to extended family about the sources of smoke exposure, as well as referral letters to primary care providers of the parents to prescribe pharmacotherapy. In the outcomes, we have reported previously on feasibility and acceptability, so we'll not touch on this before. It was very feasible and acceptable. I will really focus on our cessation outcomes, but particularly on the hair nicotine levels in our trial. And the hair nicotine was measured in all children with CF participating. So, and actually, the person who did collect the hair samples is here in the audience. Stephanie. Hair samples were trimmed to 3 centimeters from the root end of the child's hair, which represents the most recent 3 months of hair growth. And prior to the analyses, hair were washed to remove any ambient nicotine. The hair was analyzed at Johns Hopkins University lab. The limit of detection was 6.3 nanograms. And for quality control, 10% of the samples from each batch were subjected to duplicative analysis, so it was very rigorously done. In the trial, we had 36 participants, 24 in the intervention and 12 in the education-only or control group. You will see that they had about 20 years mean years, smoking years, about 14 cigarettes per day. Nicotine dependence was moderate, but the perceived stress, according to perceived stress scale, was very high, which is something that came up consistently as people do smoke because it's a coping mechanism that they believe works. In terms of cessation, at the end of the 6-month period, here you will see the control group, the intervention group, and the overall sample. Overall, we had 17% quit rate at 6 months. For reference, in the general population, it's about 7%. In other randomized clinical trials, it's about 15%, so we did fairly well. What is important also to notice is that more than half reported smoking less, even if they had not fully quit. So we had overall decrease of 5 cigarettes per day from 14 to 9, and these results were statistically significant, although this trial was not powered as an efficacy trial. Still, the fact that we were able to report significance even in that very small sample was very encouraging. Now, here is the actual story. When we look at the hair nicotine concentrations, you will see from left to right the education-only or control group, the intervention group, and then the full sample. And you will see baseline 3 months and 6 months. You will see that in the intervention group, hair nicotine decreased by 1.6 nanograms per milligram from 2.7 to 1.1, and it was very significant even in the small sample. But we had a very meaningful increase also in the control or education-only group. We had a decrease by 1.0 nanograms from 2 to 1, and it was significant. So in the full cohort, we had a very large significant effect. The other analysis that we did with the hair nicotine is we look at the threshold of exposure, and in prior literature, it has been set as at 1 nanogram. So if you are below that threshold, you really are not exposed to this tobacco smoke. So not surprisingly, at baseline, 100% of the hair samples were above the threshold of exposure because these were children living with tobacco users or having tobacco users in their extended family, even if they did not live with them all the time. When we look at our 6-month data, we see that only 39% of the intervention group and 57% of the education-only group were above the threshold, which means that we were very effective of removing exposure based on hair nicotine levels for these children. And 73% of the intervention group and 43% of the education-only group had more than 50% reduction in their baseline level of hair nicotine. When we followed up qualitatively with our participants, doing interviews with caregivers as well as with clinical providers, we noted 4 recurring themes that explain some of the success of this trial. What caregivers told us that this study did, it increased their awareness about the sources of the exposure and the harms of the exposure. And here's some supporting quotes. A parent said, I smoke outside, but the third-hand smoke was a whole other thing that people don't really think about. Another one said, I didn't know just how bad it was. They also shared that they felt that it helped increase their self-efficacy for quitting. They believed they could do it. One said it built up self-confidence because you didn't feel alone. And another one said, even the study is over, I'm not giving up. So even those who were not fully quit, they felt that they could do it. And seeing the results with reduced exposure based on hair nicotine levels was very encouraging. Everybody acknowledged how effective the counseling by tobacco treatment specialist was. And somebody said, I was just more mindful about what my triggers were. And then providers also endorsed the integration of the TTS and the CF care team. I'll draw your attention to the last quote by provider. As somebody who said, people don't necessarily disclose until somebody really focuses on that and is willing to take the time and to establish rapport. And this is why I would like to focus on the benefit of education and screening. When we talk about education, we usually say, well, that's not enough, it's not very effective. Here is an evidence that when the education is specific to the to cystic fibrosis, to the child, to the health of the child with CF, to the efficacy of the CFTR modulators that they're taking and delivered in a professional way by trained specialists, it actually is quite effective. And in fact, by month 3, 1/3 of our control group, they requested to get the full intervention. And I ask you, how many smokers ask for that? It's pretty rare. So caregivers are eager to benefit from programs if they perceive them as appropriate and helpful. And the last point I want to make is the benefits of screening. There is a lot of misunderstanding that we found in CF families about what smoke exposure constitutes. And also lack of careful screening by CF providers, and that results in very substantial underreporting of the prevalence of the problem. So from our own CF center in a state where the smoking prevalence is 21%, prior to the trial we had 19.5% prevalence based on family self-report, which matches with the population mean. After the in-depth screening by our TTS, we, of the 241 families screened or children screened, 57% ended up being exposed but not documented, not recorded as such. So when you look at the CF registry and tell me, well, as a center we don't have exposure, we don't have 10%, my answer to this is, well, go back and ask again, because I'm sure it's not 10. So why we believe this trial was successful is because it was based on theory. It was informed by extensive qualitative work. The trial and its design was developed with a very detailed input from caregivers and providers. The education was specific to CF. It focused on the child's health. It engaged extended families. I remember the letters to family members taking away the burden from the parents to telling aunt and uncle why, we can't bring Charlie to your house. Screening children for smoke exposure, acknowledging the nicotine addiction and the CF caregiver stress. Was a big one, using non-judgmental support delivered by a trained professional and providing NRT and the longitudinal follow-up. So in summary, both groups actually benefited, both intervention and education to different extents. 2.5-fold in the intervention group versus less than 1.9 times reduction in hair nicotine, respectively, in the two groups. And 61% and 43% respectively had their children with hair nicotine below the threshold of exposure at the end of the study. So considering the large effect of smoke exposure on the CFTR modulator efficacy, we believe that trials like this can be very helpful in optimizing outcomes for children with CF, and I'll end up with a call to action. Smoking cessation has to become a standard part of CF care. It's a low-hanging fruit. It's one of the few modifiable risk factors, and there's no reason why we cannot do it, as we just demonstrated. Oh, sorry. The most important slide is the acknowledgements. Robin Gers, Kathy Mims, Stephanie Gamble, who is also now a trained tobacco treatment specialist, so you can build the infrastructure to carry on this work, make it sustainable. And research collaborators also in the audience, Sigrid Ladoris, and two other nursing students who are now faculty members, and my colleague Sami Niranjan, and thank you to the children with CF and their families.
Okay, thank you so much, Dr. Oates. We have a question in the Q&A to start with. How did your team engage families in this type of intervention when many families may feel shame or guilt about smoking with a child with CF in their life?
And that is the question. You cannot do that with shame and guilt. This is one of the first things we learned in our qualitative work that informed this trial. And that's why we did it in the way we did it, by a trained professional who normalized the behavior and focused on it in the right way. I think it's important to do this in a way that's not shaming people. And there's a way to do that, and it's part of the training of TTS. And I'm sure that our psychology colleagues are trained in how to do that too. But there is no way forward if you're going to approach it from the point of shaming people for what they do.
Hi, I'm Sarah. I'm a social worker at a pediatric hospital in Arkansas. And I just want to say shout out to the team that fixed the sound. It's significantly improved. And thank you for speaking slowly. Your presentation, I feel like, is very hopeful and very exciting for ways that we can help our families. I feel like I'm pretty thorough in finding out their exposure to second and third hand smoke, but then beyond and saying, here's our state's be well, quit line information, like having some tangible educational information that I can share with them that's tailored to their kiddo with CF that they care about. So thank you so much.
Thank you. I'm not sure. I'm just looking.
I think she was just thanking you for doing this.
Oh, okay, thank you. Sorry, I told you East European and Echo don't mix well.
Can you talk a little bit, Gabriella, about the clinical implications of different nicotine levels in the hair samples? Like, what does the reduction mean in terms of potential exposure?
So I can't do this from this data set, but what I know from other studies, and most of them are outside of CF, that there is no level of exposure above the threshold that's safe. And the reason we know that is even in households where there is complete indoor smoking ban, so nobody smokes indoors, just as most of our CF families, they all smoke outside. When you do blood tests for nicotine levels, they're up to 7 times higher in the children who live in those households. We also know from our paper on ivacaftor from the GOAL study that even the very minimal levels of nicotine detected in urine are associated with increased sweat chloride, which would mean then that the CFTR modulators efficacy would be affected. There is a paper being presented on Saturday as part of the Best in the 3 journals, Best in Journal of Cystic Fibrosis, that reports our real-world data on how smoke exposure impacts efficacy of Trikafta or ATI. I can't give you the exact number, but based on all the sum of all this evidence, any exposure is not good. Thank you.
And a question from the Q&A, how would a care team member become a trained tobacco cessation person who can work with patients?
Thank you for this question. I accept responsibility for this not having had happened until now. We actually surveyed pediatric CF centers in asking whether they would be interested in a CF-specific training that would provide them the infrastructure of these programs to be delivered across programs. And we had an overwhelmingly positive response. 55 people said, yes, bring it on. We were supposed to start it in January of this year, and it did not happen because we lost our TTS. What did we do about that? We trained 2 other TTS. So when we go back home, we need to get back to the drawing board and start planning this so we can start offering it after the January 1-year delay. Sorry about that.
Hello. Thanks for the information. I just have a question. You're talking about tobacco, but we know that some states allowed us to smoke marijuana. It's any studies that it's going on about the effects of smoking marijuana on CF patients?
It was about yeah. We did not screen for that, but I know that there is some work being conducted. If you're in the audience, please feel free to chime in. Yes, there is work. And I can't comment on it very much because I'm not well familiar with it.
Okay, thank you.
I think there is a session, though. I'm pretty sure that there is a session on substance use that includes marijuana, and it's later, maybe tomorrow. Yeah.
And another question, does CCF include any education on e-cigarettes and potential exposure to harmful chemicals as a result of vaping?
Yes,
is this something you're looking into?
Thank you for the question. It totally did. We also had a separate study, just a total census of our 11-year-olds and older about their exposure to vaping as well as active vaping. But when we screened, we did consider vaping. We do know, and by the way, if you're curious, the prevalence when you ask parents is very much lower than the prevalence when you ask the adolescents themselves. About 20% at the time, that was like a couple of years ago, about 20% of our adolescent population was exposed to vaping alone. So yes, the active substance, that's common between the vapor and the cigarette smoke or any other burning tobacco product smoke that's directly related to CFTR is acrolein. And acrolein is very much prevalent in vaping, and that's why vaping is harmful to the CFTR gene, to the protein, to the folding, to the all the downstream effects and the efficacy of CFTR modulators. This was also part of the series of published papers.
Great. And given the results from the educational poster alone, can it be made available for print to post in our clinics?
It was uploaded to the CF Foundation educational, I don't know what the thing is called. You can download it and use it. We even sent it out to Greece. The clinic reported it. It's all available for use. Feel free to adapt it as needed.
Fantastic. Thank you so much, Dr. Oates. So next up, I'd like to introduce Dr. Emma Lyons. Dr. Lyons is a psychologist at the Children's Hospital of Colorado and will be speaking with us about associations among body image, dissatisfaction, body esteem, mental health, nutritional status, and ETI adherence in people living with CF.
There were a lot of associations.
Go better.
Okay. Kind of. Okay, I'm hopeful that the echo is a little bit better, but I will try to speak slowly. We'll see if I'm successful. Hi, everyone. I am so excited to be speaking to you today on findings from a large multi-site survey study called the Your ETI study, or YETI for short, which was designed to better understand ETI adherence among people with CF ages 7 years and older. In the YETI study, we examined many factors that could affect ETI self-management, and today I'll be speaking about body image, mental health symptoms, and nutritional status. No? Keep going. Okay, keep going. Okay, this is my disclosure slide. So we all know by now that nutrition and weight management are really central to CF care due to the direct impacts on pulmonary outcomes and life expectancy, and we've seen pretty significant shifts in the landscape of nutrition and weight management since ETI made its grand appearance. So pre-ETI malnutrition and lack of weight gain was standard for people with CF, and the necessary focus on weight gain and adequate nutrition combined or contributed to an increased risk for body image concerns for many people. And although findings were mixed, several studies showed a general trend where females with CF were typically more satisfied with their thinness versus men who generally wanted to be larger. And this aligns with our Western cultural ideals promoting thinness for women and muscularity for males. And in the post-ETI era, due to improvements in nutritional absorption and the ability for people with CF to gain or maintain weight, we've actually seen the prevalence of overweight and obesity increase. But there's actually very little research on how body image concerns may have shifted, or even if they have shifted after taking ETI, especially across age groups. So in childhood and now into middle and older adulthood as well. So body image is a really broad concept, but everybody has it. So if you have a body, you have a body image. And it's a person's general thoughts, feelings, and perceptions about our body. A more positive body typically correlates with emotional and physical well-being, improved mental health and quality of life, engagement and health-promoting behaviors, whereas a lower or more negative body image can indicate low self-esteem, increased risk for depression and anxiety, and disordered eating. So in our study, we examined two separate constructs of body image: body dissatisfaction, which just describes a person's evaluation of their body shape and size, and body esteem, which is the perception of physical appearance and how it is viewed by others beyond just shape and size. So the objectives of the study were largely descriptive and exploratory. We wanted to describe how body dissatisfaction and body esteem present in people with CF across age groups, and also between males and females, and among those in different nutritional status categories. So people who were categorized as underweight, and in people all the way to people who are considered obese. We also wanted to explore associations between body dissatisfaction, body esteem, and mental health symptoms, and ETI adherence. So all of those things. So as I mentioned earlier, this data came from the YETI study, which is a multi-center cross-sectional study. Data was collected from March 2024 to September 2024 at 11 pediatric and 7 adult CF care centers across the U.S. Eligible participants were people with CF ages 7 and older who were prescribed ETI for at least 18 months. They were English speaking, and they were able to complete online survey questionnaires. Caregivers of minors were also recruited alongside their children, and ETI regimen and health data were abstracted from the medical record. Okay, so this is a busy slide, but I will walk you through it. This is a breakdown of our measures. So body dissatisfaction was assessed by the Kids Eating Disorder Survey for children ages 7 to 12, and for people 13 and up, we used the figure rating scale, and both include schematic female and male silhouettes ranging from thin to obese. And participants rated their current and their ideal body image. And then the discrepancies between current and ideal indicated body dissatisfaction. And there were 3 different categories of body dissatisfaction. So do not want to change, which there was no discrepancy between current and ideal, want to be thinner, and then want to be larger. Body esteem was measured by the body esteem scale, which is a 20-item measure of self-evaluation of body image, and higher scores on the BES indicate a more positive body image. For mental health symptoms, we used the CESDC, yes, for children ages 7 to 11, and the SCARED, also for children ages 7 to 11. And for ages 12 and up, we used the PHQ-8 and GAD-7. For ETI adherence, we used the medication possession ratio, or MPR, using pharmacy refill data for the 1 year prior to study enrollment. And then last, for nutritional status, we used the criteria on this slide. I'm not going to read all the numbers, to categorize different nutritional status categories, essentially. So we had underweight participants, overweight participants, healthy or kind of target weight participants, and obese participants. And I do want to mention that actually a lot of thought was put into the terminology for these categories, and especially into this healthy weight or ideal category. But we want to recognize that this phrase may be somewhat stigmatizing because it indicates that the participants who fell into the other categories are not healthy. So if anyone has suggestions or of other terms to use for these categories, I welcome your feedback. Okay, so to describe our participant sample, participant age on average was about 26 years old and ranged from 7 to 74, which is pretty cool. The sample was predominantly white, non-Hispanic. Average BMI and BMI percentiles actually did fall into that healthy range. And the mean FEV1 across all age groups was almost 96%. And on average, participants had been taking ETI for almost 4 years. Okay, I have a lot of graphs to show you, so buckle up. Body dissatisfaction. This first kind of set of pie charts shows just frequencies of body dissatisfaction and then direction of body dissatisfaction for the full participant sample. And when I say direction of body dissatisfaction, which I'll be saying a lot, I'm referring to those 3 categories. So do not want to change my body, I want to be larger, or I want to be thinner. So overall, about 2/3, or 65% of the participants endorsed some type of body dissatisfaction. And in terms of the direction, about 28% endorsed wanting to be larger, 37% endorsed wanting to be thinner, and about 35% endorsed not wanting to change. Okay, and these charts show body dissatisfaction by sex, and this was sex assigned at birth. So body dissatisfaction was almost the same for males and females. That's this first kind of blue graph up here. But the direction of body dissatisfaction differed. So a higher percentage of males wanted to be larger, while a higher percentage of females wanted to be thinner. This was to be expected, and is similar to what we saw pre-ETI and what we tend to see in the general population. So for body dissatisfaction, separated by age groups, we had a pretty wide age range here, which again, I think is pretty interesting. What we're seeing here, the orange is do not want to change, The blue is want to be thinner, and the green is want to be larger. And body dissatisfaction trended upwards with age. So even though more than half of children and adolescents still experienced some type of body dissatisfaction, this trended up to more than 70% in adults ages 26 to 35. And in the older participants, 36 and up, a greater percentage wanted to be thinner specifically. Okay, for body esteem, the average score in the sample was almost 15. This is not a particularly high score, but it's also not particularly low. It's about a C. Body esteem varied significantly across age groups, with the highest mean score among child participants and the lowest score among adults ages 36 and up. And actually, males had a significantly higher body esteem than females. Okay, now I'm talking about adherence. So the mean MPR for the sample was about 80%, which is relatively high and is also consistent with other studies examining MPR data for ETI adherence. So this was a very adherent sample. And despite this, no differences were found in ETI adherence when comparing the direction of body dissatisfaction or body esteem, meaning that for this very adherent sample, body esteem and body dissatisfaction did not relate to ETI adherence in any way. So even though people here are endorsing body image concerns, it did not seem to impact their ETI adherence. However, this study required that participants be prescribed for 18 months, prescribed ETI for 18 months prior to their enrollment, and unfortunately, we didn't capture participants who stopped taking ETI for any reason, including due to weight gain. So body image concerns may look entirely different among people with CF who found potentially ETI-related weight gain to be so distressing that they stopped taking it. And another limitation of using MPR data in general is that it doesn't necessarily mean that a participant is taking their medication, just that they're refilling it. So using additional measures of adherence is an important continuing step. Okay, this table shows associations between body esteem, body dissatisfaction, and mental health symptoms. And there's a lot of significant P's here. But essentially what we're seeing is that lower body esteem scores were associated with higher symptoms of depression and anxiety, and there were differences in body dissatisfaction as well. So those who endorsed body dissatisfaction did report significantly higher symptoms of depression and anxiety. And when you break it down into direction of body dissatisfaction, those who wanted to be thinner also had significantly higher depression and anxiety symptoms. Okay, so now we're talking about nutritional status. There's a lot in here. Okay, direction of body dissatisfaction varied significantly by nutritional status category. So here what we're seeing, the white here is do not want to change. The light gray is I want to be thinner, and the dark gray is I want to be larger. And what's interesting here is that none of the participants who are classified as underweight reported that they wanted to be thinner, which is a good thing, compared to almost 61% of overweight and 70% of those who were obese endorsed wanting to be thinner. And this next graph shows differences in body esteem scores by nutritional status groups. So individuals who are in the obese category actually had significantly lower body esteem compared to individuals in the healthy weight range. And overweight individuals also had significantly higher body esteem compared to individuals who are classified as obese. Okay, this is the last graph. Finally, this last graph shows differences in body esteem scores across the direction of body dissatisfaction. So participants who did not want to change, so essentially who had no body dissatisfaction, had significantly higher body esteem than those who wanted to be thinner or larger. And those who wanted to be larger had significantly higher body esteem than those who wanted to be thinner. Okay, what does this all mean? I'm going to break down some of the kind of key clinical implications here, because that was a lot to walk through. So body esteem uniformly worsened with age. So the highest body esteem was reported among children, while the lowest was among adults ages 36 and older. And body dissatisfaction actually followed a similar trend, except for adults aged 26 to 35, it's kind of the youngish, middle-ish adults, reported the highest levels of body dissatisfaction across all groups. And this pattern may reflect a couple of things. It could be, kind of the cumulative impact of chronic illness in general, or the buildup of societal pressures on body image, and also just the increased likelihood of weight gain that accompanies aging. But these trends also may relate to when individuals began ETI treatment. And given that ETI has been approved for about 6 years now, adults included in this study may have been more cognitively aware of their experience with CF pre and post ETI. And in contrast, children and adolescents may have been somewhat protected from the changes solely due to their developmental level and just level of awareness. But this study didn't collect weight changes pre and post ETI, so we can't really determine if ETI-related weight gain actually contributed to declining body image. Okay, so as I mentioned earlier, consistent with pre-ETI trends, males were more likely to want a larger body, and females were more likely to want to be thinner or remain the same. And interestingly, this trend was consistent across the entire sample and did not differ by nutritional status category. So clinically, this is meaningful because people with CF in the healthy weight range were also at risk for body image concerns, despite kind of objective markers of positive health like BMI. So as clinicians, we may want to consider that body image might be relevant to all people with CF, regardless of objective weight class. And it's also really important to consider how cultural messages about men's versus women's bodies may impact our approaches or their approaches to CF care. A really also crucial and important limitation to note is that this study did not include gender diverse people with CF and only utilized sex assigned at birth. And this is important because the unique needs of transgender and gender diverse people with CF is highly understudied and really very crucial, especially considering that body image concerns are pretty nuanced among this population. Okay, so people with CF classified as obese overwhelmingly reported the lowest body esteem across nutritional status groups. And these findings are critical when considering the emerging prevalence of overweight and obesity in people with CF post-ETI and its potential impacts on health. So people in the obese category also overwhelmingly reported a desire to be thinner. And although wanting to lose weight may support aspects of physical health, it can also be very psychologically distressing, particularly given our finding that body esteem was the lowest among this group. And as we saw earlier, wanting to be thinner and lower body dissatisfaction were related to worse mental health symptoms across groups. So it's really important that conversations about weight and weight loss are collaborative and personalized, and especially non-stigmatizing to prioritize both physical and psychological well-being. So talking about health-promoting behaviors or markers of health other than BMI can encourage kind of holistic and comprehensive health improvements, and actually discussing the psychological components of weight and body image as they relate to CF can contribute to more productive conversations. But as individuals who are obese face societal stigma and discrimination, it's really essential that we approach weight-related conversations with a non-biased and patient-centered approach. Okay. Last, people who expressed a desire to be thinner had the lowest body esteem of all groups. So this is consistent with research showing that the thin ideal is pervasive among people in westernized cultures like our own and has pretty detrimental impacts on psychological well-being and self-esteem. So we should really be attuned to comments that our patients make about body size in general, because it might reflect more complex feelings about body esteem and self-worth. Body esteem also might be a potential target for intervention. So we can start to kind of focus on a person's overall sense of value and respect for their body, which may foster overall kind of a more positive body image or a more neutral body image. But more research is definitely needed to fully understand how these concepts might differ, especially in a sample that is more diverse and also whose adherence is a little bit more variable. And thank you to everyone.
Yeah, please go ahead over here. Here? Yeah.
Okay. Stephanie Foligno. Thank you, Emma, for a really, really important talk. I think overall, the information is so critical, and I think the way that you've analyzed it is really thoughtful. I'm just here to put a shout out for folks. If you haven't planned your day tomorrow, there are some really fantastic nutrition and behavioral health based talks. One is 2:30 to 4:30. It's the individualizing nutrition care, the health behavior perspective. Thank you.
Cool. Thank you.
Hi, I'm Hazel from Emory. I have a question. I'm not sure if I missed this. Your participants were like those that show increased depression and anxiety. Had they already been diagnosed and been on treatment, or either like counseling or medication-wise?
Would you mind repeating your question? Sorry, we had some trouble hearing up here.
Yeah, my question is about if your participants, the ones that had increased depression and anxiety, if they had previously been diagnosed and undergoing already either seeing a therapist or being like in SSRIs and things like that. Yeah, it's worse.
Okay, yes, okay, thank you, sorry. That was so bad. They were not. So the sample, the scores on all of our mental health measures were not clinically significantly elevated in kind of a majority of the way in the sample. So they were not, well, some might have been receiving treatment or on medication, but that wasn't information that we collected as part of this study.
Yeah. Okay, thank you.
Yeah, over here.
Hi, thank you, Dr. Lyons. Chris Drescher here from Augusta University. Really enjoyed the presentation. I had two questions. The first was, were there more concerns around body dissatisfaction, body esteem in your sample compared to the general population, or do we just live in a culture where everyone hates their body? That's my first question.
That's such a good question, Chris. The rates that we saw were comparable to the general population, and I think we live in a society that has really ingrained beliefs about what bodies should look like and how bodies should be and move in the world. And I think it means something different in people with CF because of the emphasis that we need to kind of pay to nutrition and weight management. So I think although the rates are similar, the meaning is a little bit different. But yeah, our society likes to tell people to be skinny.
For sure. Thank you. And then my second question, maybe this will be more answered in some of these other sessions as Stephanie was mentioning, but thoughts about treatment. I mean, these domains are typically handled in eating disorder clinics. That would be the areas that have done the most research around some of these domains like body dissatisfaction, body self-esteem, but that's a really specialty area that most CF centers are not going to necessarily have access to for patients on a regular basis. So just thoughts about key skills or kind of ways we can address this in clinic with our patients.
That's a really good question. So just because somebody might want their body to look different doesn't necessarily mean that they have an eating disorder or that they have disordered eating. But the ways to approach both can be similar and also very different. But I think one of the similarities is simply asking people how they feel about their body. And asking if people want to lose weight or want to change their body or be more muscular, understanding why. What is this going to mean for your life? What is this going to mean for who you are and your identity? And really kind of getting at the underlying reasons why this is important to them. And it's the same, I think, for eating disorders. Like, what purpose does this serve in your life, and how can we work together to figure out ways to address it in a way that is not distressing to you? Does that make sense?
Yeah. Thank you so much.
Cool. Thank you.
Thank you so much, Dr. Lyons.
Yeah.
Okay. Our final speaker, I'm happy to introduce Dr. Senthil Sankararaman, who will be talking today about adverse associations between GI disorders and anxiety depression. Dr. Sankararaman is an associate professor at Case Western Reserve University and a pediatric gastroenterologist in the Division of Pediatric Gastroenterology and Nutrition at Cleveland Clinic Children's Hospital. And this might be the first time we've had a gastroenterologist talk at the Psychosocial Research Showcase. So that's awesome. So welcome.
Thank you so much for the kind introduction and also for the invitation. So another study with adverse association. This is my disclaimer, or general disclaimer. This is my disclosure. So as a gastroenterologist, I have been in CF, part of CF clinic for the past 8 years. And I do see most of the patients referred to me either have anxiety or depression. So diving a little deeper, we know this very well, the gut-brain axis. Like any person with chronic disease, have increased risk of developing these disorders, both anxiety and depression. So there are a lot of studies which compared with other chronic disease models, for example, chronic asthma or epilepsy, type 1 diabetes mellitus, and these disorders don't have much abdominal symptoms compared to abdominal symptom disorders such as inflammatory bowel disease, irritable bowel syndrome, chronic pancreatitis, and we could see that the anxiety and depression, especially in GI disorders, are way high, and that has been proven well. So CF being a multidisciplinary disorder where patients may or may not have GI manifestations, so then we wanted to see whether presence of GI symptoms, how much it has an association with anxiety and depression. And also, as we all know, the reason modulator therapies improved the pulmonary symptoms really well, but the extrapulmonary symptoms improvement remains still modest. So So here and then there are few studies which have shown that people with GI diseases in CF do have increased anxiety and depression, but there is paucity of data at the national level. So our aim is to evaluate the association between GI symptoms or GI disorders and anxiety and depression among people with CF. And we hypothesize that a higher prevalence of anxiety and depression in people with GI manifestations. So for this, we use a large data set. So people who are not familiar with large databases, one we use here is called TrainerText. It is a quick way of looking at associations, but the major disadvantage is we cannot get all the information we wanted to do. Like for example, if we do a retrospective chart review, we can kind of like add more variables and evaluate more precisely, whereas in big databases, that's kind of like a big limitation. So this TrainerText database, it's predominantly US. There may be few international centers as well. It includes all age group. It's not specific for CF, like we can use for any other diseases as well. And here we included closer to 103 healthcare networks. And we used a cross-sectional methodology and included all people with CF. A predominant part of our cohort is mostly adults, but we do include children as well. And we divided the cohorts into two big categories, presence of any GI manifestations, the one listed here. Some of them are very common, as we know, like constipation, acid reflux, and people also get DOs, things like that. And some of them are rarer, but does produce higher impacts, such as chronic advanced liver disease and pancreatitis and things like that. So we also evaluated other comorbid conditions, for example, presence of malignancies or transplantation or diabetes do have, because of the chronicity and impact, can also have adverse association with anxiety and depression. So we included those as well. So we used the ICD codes, which are just diagnostic codes used for like diagnosis to evaluate these variables. And then also we did a matching score called a propensity score matching to see how much of the common variables we used, like age, sex, and the other comorbid conditions also impacted the outcome. And we used anxiety or depression as outcome variable. So we identified closer to 33,000 people with CF, which is kind of correlates the number we get from registry. And a staggering 1/3, like closer to 33%, had at least one of the GI comorbidities I listed. And people with GI comorbidities also had increased prevalence of other comorbid conditions, such as the one we evaluated, like diabetes mellitus, malnutrition, transplantation, and malignancies. It's a little bit busy slide. What trying to show is like the two cohorts with GI comorbidities, without GI comorbidities. There were some changes, like a little bit older, significantly less number of females, and then higher prevalence of whites in this group, and then less percentage of Hispanics. And then if you see all the comorbidities, all were increased in this group compared to people without GI comorbidities. So then we did the matching to just kind of reduce the confounding factors, and we got 10,000 in either group. So after matching, we still see that the proportion of people with anxiety or depression was significantly higher, 50% in the GI group versus 14%, so almost like 3 times higher with statistical significance. And then also the hazards ratio is closer to 3.5, so 3.5 times higher prevalence of either anxiety or depression in people with GI disorders. So this is a Kaplan-Meier analysis showing that taking all people with CF into account, and with the development of any first GI manifestations, then we can divide into two cohorts. So the green cohort is without GI disease. So the chance of developing anxiety and depression is much lower compared to the persons who had GI disease. So basically means that like once they develop GI symptom, the chances of the anxiety or depression is going to be way higher. So why people with CF having increased mental health disorders? This group is very well kind of like know the reasons. It's a multi-system manifestations, increased disease burden, frequent hospitalizations, frequent diagnostic and painful therapeutic procedures. All could just from the younger age could increase the anxiety and depression. And what is the association between GI and mental health? So GI symptoms, unlike other symptoms, it's kind of intractable, responds poorly to therapy, and also the associated social stigma. Like it's much easier to say my head is hurting rather than saying that I have bloating or constipation or I have flatulence and things like that. And then also, as I mentioned, the gut-brain interaction is another reason. And then many studies have shown that the role of microbial dysbiosis playing the increased anxiety and depression in GI conditions as well. So coming to the limitations, since it's a retrospective study and using a database, a lot of things we wanted, but we could not evaluate. For example, like how the anxiety and depression was diagnosed, what screening method was used, and what is the CF genotype and phenotype, what are all the GI management that were used. And then also more important history, such as like family history, social history, those things we could not evaluate. And also the other important thing, the quality of life. So what is the adverse impact on the quality of life also we could not get due to lack of the diagnostic codes. And this is association. That's one of the big issues with retrospective studies, as we all know. We cannot infer any causality. It's just a bidirectional association between these two. So then to conclude, people with CF with increased GI comorbidities have adverse association or increased association with psychological disorders, either anxiety or depression. And then how we can approach. Further studies can be done to kind of like delineate what are all the reasons which kind of like, which worsens this relationship or which kind of like leads to this relationship, and then kind of tackle that accordingly from much earlier. Prospective trials also will kind of help us to address this. These are my references. And thank you for listening. This is our study team, and I'll take questions.
Can you, so the anxiety and depression were, again, just ICD-9 or ICD-10 diagnosis, that's how those were pulled?
Right.
Okay.
That is correct.
Do you have any initial ideas about next steps for looking at how to mitigate the increased risk of anxiety and depression in this population?
That's a great question. I think now we know that we do the screening, both GAD7 as well as PDQ8. So that's one way. And then also more increased awareness, especially if patients have increased GI symptoms, and then referring to us much earlier or managing that also kind of like will help. Again, I'm not like as a GI specialist, I'm trying to sell my specialty a little higher, but then definitely having GI symptoms down the line causes a lot of anxiety and depression, vice versa also. So kind of tackling both also do help in patients to reduce the entire comorbidity.
Hi, I'm Christina. I am from the Spokane Center. I'm the social worker at our center, and we kind of have a working theory internally about a lot of our patients experiencing visceral hyperalgesia or visceral hypersensitivity, kind of just along the lines of your talk of like how we as mental health professionals in the clinic can help patients maybe recognize those symptoms that they might be having, since like behavioral therapy, cognitive behavioral therapy is kind of one of the treatments for patients who experience those symptoms.
Yeah, so no, definitely it's a really good question and good comment also. So just the other thing, due to limitations, oftentimes we over-rely on pharmacotherapies, which typically in GI disorders, chronic GI symptoms may or may not work, oftentimes may not work. So tackling in all aspects, whatever resources available locally, like CBT, hypnotherapy, or relaxation, kind of like mindfulness, things like that, like whatever we can offer, or even just talking to the counselors frequently, that definitely will help in kind of addressing the both as well.
All right, thank you very much.
Thank you.
All right, thank you all.
Just turned Thank you all for attending this session, and thank you so much to our 5 speakers today. Really wonderful job. Yeah, and all of these posters will be available in the exhibit hall if you'd like to take a look during the poster sessions. Okay, thanks.